Green stick fracture. Green stick fracture is a type of incomplete fracture which occurs only in children where the bone bends and cracks instead of breaking. It happens in the bones of children because they are more resilient and spring-like. Bending force when it is applied to the bone, the outer cortex breaks. That is, the convex surface breaks, while the concave surface, that is the inner cortex, it bends like a green stick. Now, the features of this is it occurs only in children. Then the site it is most commonly seen in the forearm bones, that is ulna, and then the clavicle. Then X-ray features, there is a crack on the convex side, there is a bend on the concave side. Then deformity, angulation is present, and displacement is minimal. Management for this is easy. That is, if there is a minimal angulation, then plaster cast or immobilization is done. If there is a significant angulation, then in that case, manual correction is needed. While the remodeling potential is good in children, so it corrects with growth. The next important topic, that is the radial nerve palsy. So radial nerve palsy, it is the anatomy. It originates from the posterior cord of the brachial plexus C5 to C8, travels in the radial groove or the spiral groove which is present in the posterior surface of the humerus, pierces the lateral intermuscular septum and divides into two, superficial and posterior interosseous nerve. Then motor branches at the level of above the level of radial groove supplies the long and the medial head of triceps. At the level of radial groove supplies the lateral head of triceps and anconeus. Below the radial groove, it supplies the extensor carpi radialis and brevis. At elbow, it supplies the extensor carpi radialis brevis and supinator, and after piercing the supinator, it supplies all the other extensor muscles. So, if the injury happens at the level of radial groove, there is going to be the wrist drop, while in below the radial groove, it happens there is no wrist drop, only finger drop is present. Now, the very important, the sensory supply, it supplies the posterior gluteus nerve, arm, forearm, and the superficial branch, it supplies the dorsum of the hand. Now, only on the lateral side. Then the types of the radial nerve palsies, and the very high radial nerve palsy, it presents above the radial groove. The triceps and all the below are going to get affected. In high radial nerve palsy, it happens at the level of radial groove, and here there is a wrist drop that is present. And in case of low radial nerve palsy, that is below the radial groove and all below, here that will lead to finger drop, thumb drop, wrist drop. That will happen. Then the causes for this are going to the fracture shaft of humerus, then compression as in case of Saturday night palsy or the crutch palsy, injection injury or laceration. Then the clinical features, there is a wrist drop that is seen, finger drop, and the thumb drop, that is the thumb is not able to extend and abduct. Clinical features, there is going to be the same drops as well as motor drops of the triceps is the this results in the loss of elbow extension. Then brachioradialis, it leads to elbow flexion, and because of which the arm remains in the mid-prone position. Then there is going to be wrist extensors, that is extensor carpi radialis and brevis. Finger extensors are the metacarpophalangeal joint, and the thumb extensors are the interphalangeal extension. So these are going to get affected. The sensory loss, there is a dorsum of hand between the first and the second metacarpal area is supplied by the radial nerve. And diagnosis is by clinical evaluation, X-ray to rule out humerus fracture, and electrodiagnostic studies that involves electromyographic EMG studies and the nerve conduction studies in CS to localize the injury. Treatment conservative, most common that is done in neuropraxia and axonotmesis, where there is a Cock-up splint that is given to prevent the wrist drop. Then physiotherapy and regular follow-up. Observation period is up to 3 months. If more than 3 months, if there is no recovery or if there is open fracture, progressive worsening takes place, then in that particular case operative exploration should be done. So operative exploration, it includes neurolysis where the nerve is compressed by the scar or the callus. Nerve repair, it is done when there is a cut nerve. Nerve grafting is done where there is a gap of 2 to 3 centimeters, and tendon transfer where there is an irreparable injury for more than 18 months. The tendon transfers that are used for wrist extension, there is pronator teres, extensor carpi radialis brevis. For finger extension, flexor carpi radialis or ulnaris, and for thumb extension, palmaris longus. Then neuropraxia has got a better prognosis as compared to neuronotmesis. Low level injuries, they have better prognosis. If the injury is closed or compression, it has better prognosis. In old age patients, there is poor prognosis, and if the primary treatment is taken, it has got a better prognosis. Recovery rate is 1 mm per day, and best prognosis among all the peripheral nerve injuries is seen in radial nerve palsy. Then another pediatric and orthopedic topic, that is physeal injuries. So injuries that involve the growth plate, that is physis in children, and which affects the future bone growth, that is called as physeal injuries. So physis is going to be a cartilaginous growth plate which is present in between the epiphysis and metaphysis, the weakest point, and the injuries may cause growth disturbances over here. So there is a classification that is called as alternate classification. It has got 5 types. So the first is separation through the physis. It is seen in slip capital femoral epiphysis, and the germinal layer over here is intact. Then the type 2 is the fracture through the physis and it goes away. So it involves the physis and it involves the metaphysis. So and the fracture fragment that gets separated, that is called as Thurston Holland fragment. Here also the germinal layer is intact. For these two, close reduction and internal fixation is done. Then type 3 is alternate classification, where the fracture it goes through the physis and low towards the epiphysis, that is physis and epiphysis involved. That involves a lower degree of fracture, Delorme's fracture, where open reduction is required. Then the 4 is through and through fracture, where the physis, metaphysis and epiphysis all are involved. That involves a lateral condyle fracture of the humerus. Again, open reduction, internal fixation is required. And type 5, that is the crushing injury. It is caused because of impaction, fall from height. So that will lead to germinal layer getting compressed, and this is a retrospective diagnosis where there is limb shortening in that particular limb. Then the clinical features, there is going to be pain, swelling at joint, tender at the level of physis, and unable to bear the weight or use the limb. Then the diagnosis, X-ray, compare with the opposite side, MRI or CT if suspected but not visible. Then complications that will lead to limb shortening, then angular deformity or joint incongruity in type 3 and 4. Then management, if it is a type 1 and 2, close reduction internal fixation and then type 3 and 4, then it's open reduction and internal fixation. And type 5, just protect from weight bearing and limb lengthening Velizaro procedure is done afterwards. Then the next is the ulnar nerve palsy. So in the ulnar nerve palsy, if we talk about the first anatomy, the origin is going to be the medial cord of the brachial plexus CAT1. Course, it goes into the arm on the medial side, pierces the medial intermuscular septum, goes into posterior compartment. In the elbow, it just passes behind the medial epicondyle, then the forearm between the two heads of flexor carpi ulnaris. In the wrist, it passes superficial to flexor retinaculum, and in the hand, it divides into superficial and deep motor branches. So motor branches for the forearm is flexor carpi ulnaris, medial half of the flexor digitorum profundus. In the hand, it supplies the hypothenar muscles, that is adductor digiti minimi, then flexor digiti minimi and opponens digiti minimi, adductor pollicis. Apart from that, all the interossea, that is a 4 dorsal ventripalmar interossea and the medial 2 lumbricals are also supplied. Then sensory supplies to the medial 1.5 of the fingers on the palmar side, and the dorsal side also it supplies the medial half of the fingers plus ulnar border of the hand. Then types of ulnar nerve palsy, high ulnar nerve palsy, it is proximal to elbow. It will supply the flexor carpi ulnaris and FDP muscles, and while the low at the wrist only supplies the hand muscles. What are the causes of ulnar nerve palsy? The causes can be the fracture at the medial epicondyle, then dislocation of the elbow, or compression at the level of cubital tunnel or Glanz canal in case of wrist. Then laceration, that is cut at the wrist, or leprosy is a very common cause in India, and delayed palsy as in cubitus valgus deformity. Now the clinical features, there will be claw hand. So there is a ulnar claw hand that is seen. It is more marked in case of low ulnar nerve palsy, because in low ulnar nerve palsy the flexor digitorum profundus is spared, and because of which there is an unopposed pull. So that is called as the ulnar paradox. So ulnar claw hand, it is more exaggerated in low palsy as compared to ulnar superior palsy, because in low palsy FDP is spared and that will lead to unopposed pull. The motor signs that can be seen will be from an A, B, C, D, E, F. That is, A stands for ulnar nerve, B stands for book test, C stands for card, D stands for the dorsal interossea, palmar interossea, abduction tests, Igawa test, and the Froment sign. Froment sign is the flexion of the thumb that is seen, that is the patient is using the median nerve. Then the sensory loss, autonomous zone. Diagnosis, clinical examination, X-ray, it rules out a fracture around the elbow, and electromyographic studies are nerve conduction studies. Then management, conservative management is knuckle bender splint, physiotherapy follow-up. Indications for exploration, if more than 3 months there is no recovery, if there is a progressive exploration, open injury. Operative procedures, neurolysis, that means there is going to be a compression by scar or callus, nerve repair if it is cut nerve. Then Nerve grafting is a 2 to 3 centimeter gap. Then something called as anterior transposition, that is, we bring the nerve anterior to the medial epicondyle. It passes below the medial epicondyle. We bring it anterior so that it prevents the tension or compression. Then the tendon transfers. Tendon transfers, it is done when there is an irreparable injury. That is, the injury has taken more than 18 months, but it hasn't repaired. So in that case, we use the extensor carpi radialis brevis tendon for adductor pollicis and introstia. Now the prognosis, if it is low level injury, it has got good prognosis. Neuropraxia has good prognosis. Compression has good prognosis, and if there is going to be late presentation, then that will have a worse prognosis. Again, the recovery rate is same, 1 millimeters per day, and shows the tenile sign progression. Then the next is the common peroneal nerve injury. Common peroneal nerve injury, the branches are L4, L5, S1, S2. It is a branch of sciatic nerve. It winds around the neck of fibula, and then it further divides into the deep peroneal nerve that supplies the anterior compartment, that is tibialis anterior extensor hallucis longus, extensor digitorum longus, and the superficial peroneal nerve which supplies the evertus peroneus longus and brevis. Now, so these are the muscles of dorsiflexion, that is tibialis anterior extensor hallucis longus, extensor digitorum longus, and if there is palsy of this common peroneal nerve, then that will lead to foot drop. So foot drop is a question that is asked. Causes of foot drop can be the neuropathic causes. Now it can be divided into upper motor neuron and lower motor neuron causes. The upper motor neuron causes, they include the stroke, cerebral palsy, and spinal cord injury up to the level of T4. Lower motor neuron causes, they include the L4, L5 radiculopathy, that is seen in PIVD, that is prolapse intervertebral disc, Cauda-Equina syndrome. Then peripheral nerve lesions, they include the sciatic nerve, which is affected above the knee, then at the level of neck of fibula because of trauma, because of fracture neck of fibula, compression or prolonged casting, that will lead to common peroneal nerve injury. Sciatic nerve is affected in posterior dislocation of hip or fracture of femur, and deep peroneal nerve is affected in compartment syndrome. Talking about the metabolic causes, it can be diabetes mellitus, leprosy is a common cause, alcoholism, and lead poisoning. Talking about the clinical features, there is a foot drop that is seen, so that foot remains in plantar flexion position, and because of which the gait of the patient is such that it is a high steppage gait, and inability to walk on the heel is present because they cannot toss it flex their foot. And motor loss, there is anterior compartment of the muscles is lost, that is tibialis anterior, extensor hallucis longus, extensor digitorum longus. With the sensory loss, the common peroneal nerve is supplied the anterior lateral aspect of the leg and dorsum of the foot. The deep peroneal nerve, it is going to have a autonomous supply to the first web space. So loss of sensation over the first web space is seen in deep peroneal nerve, and the dorsum of the foot is supplied by the superficial peroneal nerve. The special sign of the tibial sign. Tibial sign is a tingling sensation about tapping over the nerve. That means the regeneration is present. Then muscle wasting. Muscle wasting means the wasting of the anterior compartment of muscles. Now level of lesion, if there is a L5 nerve root that is getting damaged, then gluteus medius is getting affected, and when gluteus medius affects, the Trendelenburg gait is seen. Then in case of sciatic nerve, all the muscles below the knee and above the knee are getting affected. Ankle jerk is diminished. In common peroneal nerve, the everters are getting affected, because of which the eversion of the foot cannot happen, and only if it's a deep peroneal nerve, then foot drop will be seen and sensory lost over the first web space. Then this level of lesion is found by the nerve conduction studies. Then diagnosis by the history, by the gait observation, motor and sensory examination, investigation, X-ray to rule out any fracture of the neck of fibula and the femur, or the dislocation of the hip. Then MRI spine for disc prolapse, electromyographic studies to look for denervation potentials, and nerve conduction studies to localize the level of injury. Blood test for diabetes and leprosy. Management, conservative management, is a splint available that is called as A4 splint, that is ankle foot orthosis or the foot drop splint. It maintains the foot in normal position. Then physiotherapy, regular follow-up is required. Surgical indications, if more than 3 months there is no recovery, progressive deterioration, open injury, right? Neurolysis, when there is a compression by the scar or callus. Nerve repair, that is where there is a cut nerve grafting in the gap of 2 to 3 centimeter, and anterior transposition of this common peroneal nerve is done. Now tendon transfers, if there is a irreversible injury for more than 18 months, and posterior tibialis tendon is taken. Other procedures include triple arthrodesis, where there is a stable joint is created by fusing all the 3 bones at the ankle joint. Then next, talking about the nerve injuries, the classification and the management for neuropraxia. So In the nerve injuries, there are two classifications: Seddon's classification and Sutherland's classification. Seddon's classification is classifies on the basis of neuropraxia. Neuropraxia means physiological interruption is present, axon is intact. Axon not means neuron not means. Axon not means where the axon is broken, endoneuron axon is disrupted, endoneurium is intact. And neuron not means no, it's completely cut. Axon disrupted, endoneurium is also disrupted, and Waller generation is seen in case of axonotmesis and neuronotmesis. Sunderland's classification is on the basis of 5 degrees. In the first degree, only conduction block is present in axonotmesis. In second degree, axon is disrupted but the endoneurium is intact. It is called as axonotmesis. In third degree, the axon is cut, endoneurium is also cut, but however the perineurium is intact. It is axonotmesis. In fourth degree, the whole fascicle is cut, but epineurium is intact, that is neuronotmesis. And the fifth degree, the complete nerve non-section takes place, that is neuronotmesis. Now, talking about the comparisons of nerve injuries, so neuropraxia, axonotmesis, and neuronotmesis. The cause for neuropraxia is continuous compression injury or maltraction. Moderate traction or crush injury is seen in axonotmesis, and cut or laceration is seen in neuronotmesis. Now, pathology in neuropraxia, there is going to be demyelination of the nerves, no structural damage is present. In case of axonotmesis, the axon is broken. Neuronotmesis, there is a complete severance. Waller degeneration is present in axonotmesis and neuronotmesis. Then the motor paralysis. So motor paralysis is complete in all the three. Muscle atrophy is minimal in neuropraxia. It is severe in case of neuronotmesis. Autonomic loss is not present in neuropraxia. It is present in axonotmesis and neuronotmesis. Tinel sign is absent in neuropraxia. It is present in axonotmesis and neuronotmesis. In EMG, the nerve conduction is normal here, and in the axonotmesis and neuronotmesis, the denervation potentials can be seen. Recovery, spontaneous recovery within weeks is seen in neuropraxia. It may be slow in case of axonotmesis, and there is absolutely no recovery in case of neuronotmesis. Surgery is required. Talking about the neuropraxia, as we have studied, it's the mildest form of nerve injury characterized by physiological conduction block. There is no structural damage. The pathophysiology is a particular segment getting demyelination. The axon remains intact. No Wallerian degeneration is seen. And causes for this are compression, mild traction, compression as in case of satellite palsy or crutch palsy. Then tourniquet palsy can be another cause. Common sites are going to be the radial nerve because of the radial grooves, then the ulnar nerve, and common peroneal nerve at the fibular neck. Clinical features: complete motor loss, sensory loss is variable, muscle wasting is not present, autonomic changes are not present, tinel sign is absent, and the pain is usually absent. On the nerve conduction studies, it is completely normal. Electromyography, no nerve denervation potentials, and chronic C is also normal. Management, just a conservative management, no surgical intervention. Spontaneous recovery is expected. And conservative measures that are used are splintage, physiotherapy, follow-up, reassurance. So, what are the different splints? Specific splints for radial nerve palsy is Cock's splint. For ulnar nerve palsy, it is knuckle bender splint. For common peroneal nerve palsy, it is a foot drop splint or the A4 splint, and axillary nerve palsy is the aeroplane splint. Recovery generally happens for neuropraxia within 2 to 3 weeks. And complete recovery happens by around 6 weeks to 3 months. The rate of recovery is 1 millimeter per day. Median nerve palsy. So the median nerve palsy, talking about the anatomy of the median nerve, first root value is from C5 to T1, so it involves the lateral and the medial cord of the brachial plexus. It begins from the arm in the cubital fossa, then it goes between the two heads of pronator teres, and then enters the forearm, that goes to the carpal tunnel and reaches the hand. Now the motor supply. The motor supply, it supplies the pronator teres muscle in the forearm, flexor carpi radialis, flexor carpi, flexor digitorum profundus on the lateral half. Then pronator quadratus, flexor pollicis longus, flexor digitorum superficialis. In the hand, it supplies the loaf muscles or the thinner muscle, that is lumbricals, first and second lumbrical, then the opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. Then sensory supplies through the lateral arm, then the palmar aspect of the thumb, index finger, middle finger, and the lateral half of the index finger. We're talking about the causes of the median nerve palsy. So median nerve palsy, it can be caused at the elbow because of the supracondylar fracture of the humerus. So supracondylar fracture of the humerus leads to median nerve palsy. Apart from that, elbow dislocation and entrapment in the pronator teres, that is pronator teres syndrome. At the wrist, it can affect at the level of carpal tunnel syndrome in the wrist lacerations. Clinical features: the motor deficits. Because of pronator teres getting damaged in the high median nerve injury, there will be loss of pronation. Then the flexion will be weak. The loss of finger flexion and loss of thumb apposition is seen. The signs of here in high median nerve injury, there will be a benediction hand sign. while attempting to make a fixed fist or a pointing index sign. In case of low median nerve palsy, at the wrist, the theta muscle wasting is seen and loss of thumb apposition is seen. So the deformity is called as the eighth thumb deformity. So the clinical tests that are used to elicit this is the pain test. So the patient is unable to abduct the thumb. So it is we keep a pin and we ask the patient to touch the tip of the pin. So that is not possible. Then opposition test is not possible. So that leads to eighth thumb deformity. Ochsner clasp test, pointing index sign, Benedict sign, and Fallon's test is used, and Tidal sign in case of carpal tunnel syndrome. So Fallon's test is like ulta namaskara position, and Tidal sign is nothing but there is a tingling sensation in the thumb index finger when tapped on the injured nerve. Then investigation in nerve conduction studies, electromyography is done, and ultrasound MRI, X-ray to detect any fractures in case of supracondylar fracture of the humerus. Management, conservative management is splintage, physiotherapy, follow-up, and surgical management is either nerve repair if there is a cut nerve graft if 2 to 3 centimeters of gap is present, or there is neurolysis if it is affected by the callus, and decompression can be done if it's a carpal tunnel syndrome, and tendon transfer in irreparable cases. For more than 18 months, if there is no repair, then that is tendon repair can be tendon transfer can be done.